United States alone, over 158,000 new cases of colon and rectal cancer are diagnosed every single year. It is a highly common and incredibly persistent disease. And this line graph visualizes a disturbing epidemiological trend. While overall screening has helped older populations, colorectal cancer is increasingly striking adults under the age of 50. The core problem we face is timing. Between 70 and 90% of colorectal cancers are diagnosed after a patient notices physical symptoms. By that point, the tumor has usually grown large enough to invade the intestinal space, meaning the disease is already relatively advanced. Compare that to patients diagnosed through routine screening while they are still entirely asymptomatic. Finding the disease early drastically lowers the risk of the cancer spreading, yielding a better prognosis. But the early warning signs that do appear, things like abdominal pain or sudden changes in bowel habits, are notoriously vague. They are incredibly easy to dismiss as minor stomach issues or a bad reaction to lunch. To cut through that noise and catch the disease early, we have to look closely at how the digestive system is built. Because these warning signals aren't random, they're directly dictated by the specific geography of your gut. Let's start with the spatial layout of the large intestine, focusing specifically on the right side, known as the proximal colon. The colonic tube on this side is physically wide, and the digestive contents passing through it are mostly liquid. Because of this extra space, tumors growing on the right side rarely cause physical blockages or cramping pain. That extra space creates a hidden danger. Right-sided tumors often bleed silently into the digestive tract, making unexplained iron deficiency anemia and extreme fatigue the primary warning signs. Now move down the tract to the left side and the rectum. The physical environment changes dramatically. This barium enema radiograph shows exactly what happens here. By the time waste reaches the left colon, the stool is solid and the colonic passage is much narrower. A tumor here acts as a physical roadblock, creating this distinct pinched apple core obstruction. Because the tumor is blocking solid waste, left-sided symptoms are highly visible. Patients experience cramping, thin stools, a distinct change in their normal bowel habits, and hematochezia, the medical term for bright red blood in the stool. Identifying whether a patient is dealing with silent anemia or a visible blockage points directly to where the tumor has developed within the colon's geography. A tumor's location doesn't just dictate its symptoms, it dictates where the cancer will attempt to spread. Metastasis follows the specific venous drainage highways of the gut. The venous drainage for the vast majority of the intestinal tract filters directly into the portal system. Because of this plumbing, the liver is almost always the first target for spreading colon cancer. But tumors located way down in the distal rectum have a different route entirely. Their blood drains into the inferior rectal vein, which connects to the inferior vena cava. This allows rectal cancer to completely bypass the liver and spread straight to the lungs. To map these specific threats, doctors rely on the definitive investigative tool, the colonoscopy. A colonoscopy moves beyond simple imaging to allow for immediate physical intervention. During the procedure, a doctor can biopsy suspicious lesions, completely remove precancerous polyps, and they can even inject tattoo ink into the colon wall to assist future surgeons during their procedures. It is the single tool that bridges the gap between suspecting cancer and physically proving it. This staging table shows the framework doctors use once a diagnosis is confirmed, mapping severity with the TNM staging system. TNM breaks the threat down into 3 components: T for tumor size, N for regional node involvement, and M for distant metastasis. To find the M, doctors run contrast-enhanced CT scans of the chest, abdomen, and pelvis before surgery, scanning distant organs for spread. But the final, most accurate TNM stage is assigned after surgery, when pathologists examine the resected tumor under a microscope. The pathologist checks exactly how many millimeters the tumor invaded through the muscular layers of the colon wall, locking in the true T and N values. These microscopic findings dictate the immediate clinical path, deciding if a patient requires adjuvant chemotherapy, radiation, or a transition into regular surveillance. The ultimate goal in defeating colorectal cancer is entirely preventative. Catch it in the silent, asymptomatic phase. If you are of screening age, undergoing routine screening is the single best way to intercept a polyp before physical symptoms ever have a chance to manifest. And for adults of any age, pay attention to the geographical warning signs. Watch for unexplained anemia or severe fatigue from the right side, and visible bleeding or stubborn changes in your bowel habits from the left. Understanding how your body's plumbing dictates these symptoms gives you the information you need to demand the right tests, catch the disease early, and drastically improve your prognosis.